So I actually wanted to do a video for you guys about cardiac arrest and then felt sick. So I decided, let me first recover. I haven't yet fully recovered though, but the content still has to keep coming. Apologies for my flowish voice. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at cardiac arrest. This is a very important topic because patients will die. Rest assured, patients will die if you do not intervene very quickly. And if you intervene very quickly, you may save a life. And of course, this is good for your experience as a healthcare practitioner. It's also good for your conscience knowing that you saved someone's life. Grab a piece of paper. Let's go. So this is very scary to see. Imagine someone is just standing in the public. All of a sudden they collapse to the ground. It appears like as if they are not breathing. They have sustained a cardiac arrest. If you haven't seen this before, very scary to see, especially for the general public. If you're in the hospital, it could be a patient that is in ICU, a patient that is in a high dependency unit, or even just a patient on the ward. All of a sudden, they become unresponsive, they sustain a cardiac arrest. So remember that cardiac arrest is just simply defined as this cessation, sudden cessation of cardiac activity that's going to be associated with no breathing and no signs of circulation. Your patient becomes unresponsive. So in essence, you have your patient losing consciousness. Number one, they will have absent major pulses. The central pulses, predominantly your carotid and your femoral pulse, will be absent. You shouldn't base your pulse on your peripheral pulses, like for example, you're checking the radial pulse, because in some patients that are in shock, for example, you may actually even have very much difficulty palpating the peripheral pulses. The patient will not be breathing, and if you don't intervene, death is going to be inevitable. So if the patient is not treated, the patient will die. Some patients may have this agonal gasps, they may have pallor, they may have cyanosis, they may have dilated pupil, and they may have brief tonic generalized grand mal seizures. Now, I'm sure you have watched many of these TV shows and you'd hear them scream different codes. They'll say code blue, for example. So whenever someone shouts code blue, it means that someone in the hospital has had an unexpected cardiac or even respiratory arrest, and they do require resuscitation. So it means you should alert everyone that is around, and a crash cart must be brought to that particular person so that you can start the process of resuscitation. Remember that cardiac arrest is going to be causing about 60 to 70% of the deaths from coronary heart disease in adults, and 10% of those that actually have this cardiac arrest are going to be alive, and most of them can actually have neurologic impairment. Sometimes if you resuscitate them for too long and you bring them back, they're brain dead. So time is of the essence here. If you intervene very quickly, you're lessening the risk of neurologic impairment in this person's life. And remember that cardiac arrest can be reversed, usually by the CPR. You can perform defibrillation or cardioversion, or even cardiac pacing. And irreversible damage is going to be happening to the brain if the circulation is not restored within 2 to 3 minutes. Remember that CPR is not going to solve the problem that is underlying. CPR just keeps pushing the blood inside the vascular system such that if this person comes back, the organs are not damaged. And if they come back, you still have to search for a cause that has resulted in this cardiac arrest and address that cause. Because if you do not address that cause, that person will arrest again, and most likely they will die, or they will have this neurologic deficit. What are some of the causes of cardiac arrest? I want you to think of 4 important things. 4 main things that can be caused by many other different things. It could be problems with the rhythm of the heart. You could be having a ventricular fibrillation. This is where you have this abnormal electrical activity that's causing the ventricles to be like, I like to say, they're shivering. And as the ventricles are not contracting as a whole, there's no effective cardiac output that is coming out. And if there's no effective cardiac output that's coming out, organs are not perfused in the body. This is the most common cause of cardiac arrest. and can be due to myocardial ischemia, it can be due to ischemia, it can be due to electrocution. It's actually the most easily treatable cause of cardiac arrest. This is a shockable rhythm. I will show you what ventricular fibrillation looks like on the ECG. When you connect your defibrillator and you actually see this tracing, just ask everyone to stand back, shock the patient, because ventricular fibrillation is a shockable rhythm. Then the next cause is pulseless ventricular tachycardia. This is often due to, it's a type of arrhythmia that's due to a re-entry mechanism. This also is a shockable rhythm. I will show you what it looks like. Asystole, where the conduction system actually fails to conduct the impulse to the heart. Here, there's no heartbeat. There's poor prognosis in this, and it's a non-shockable rhythm. This is when the patient flatlines. You just connect the ECG and you just see a flat line. Here, this is what actually pisses me off in most of these medical shows. You see that a patient has flatlined and they rush for the defibrillator. No, do the chest compressions, do the CPR. This is a non-shockable rhythm. Then another cause is what's known as the electromechanical dissociation. It's now referred to as the pulseless electrical activity, or PEA. So remember here, you may even have normal cardiac activity. Sometimes it may be organized, sometimes it may be partially organized, but they don't have a palpable pulse. So you connect your ECG, they have a normal rhythm, you can see the ECG tracing, sometimes it's a bit of some abnormalities, but they don't have a pulse. This again is not a shockable rhythm. So the pulseless electrical activity was previously referred to as electromechanical dissociation, and here the heart is not going to be able to pump this adequate volume to maintain systemic perfusion. So if you connect an ECG and you see that there's a normal ECG tracing, but there's no cardiac output, this means that this person could have a PEA. It's seen in patients that have cardiac rupture. It's seen in patients with massive embolisms. And remember that rhythms like ventricular fibrillation, even the pulseless ventricular tachycardia, they are not associated with pulseless electrical activity. Despite these things also not having a pulse, they are not going to be associated with PEA. So the pulseless ventricular tachycardia and ventricular fibrillation, those ones do respond to defibrillation because they are shockable rhythm. PEA is a non-shockable rhythm because the rhythm is normal. So why do you want to shock this patient? So in contrast to adults, if you see cardiac arrest in children, most of the times it's often attributed to hypoxia. So address the hypoxia first as you're doing the chest compressions. So even if you perform the compressions in a closed CPR form and you do it to good effect and they're effective, it only provides about 25% of the pre-arrest cardiac output. So the coronary and even the cerebral blood flow are going to be about 5% receiving blood in the coronary arteries and 10% receiving blood to the brain. Early CPR as well as defibrillation witnessed cardiac arrest are actually critical to improving chances of survival. So if you actually notice that this person has gone into arrest and you institute management there, their chances of survival are much better than someone who is more or less, I can say, you're receiving second-hand information. So remember, ventricular fibrillation, pulseless ventricular tachycardia, those are shockable rhythms, while as asystole and PEA, pulseless electrical activity, those are non-shockable rhythms. This is an ECG tracing showing you ventricular fibrillation. As you can see, I like to call them, you just see squiggly lines on your ECG. This is a shockable rhythm. Shock your patient. If you see again, this also looks like squiggly lines and there's no pulse. This is also another shockable rhythm. This is pulseless ventricular tachycardia. Then here is a patient that had the PEA, the pulseless electrical activity. So you may get an ECG tracing that looks organized or partially organized. You may get a normal ECG. So here, this one is a non-shockable rhythm. So it could be patients that have a sinus rhythm, patients with atrial fibrillation, patients with bundle branch blocks, patients with idioventricular rhythms. These are non-shockable rhythms. You're going to be treating them without having to defibrillate your patients. Then if you see a strip that is just like a straight line, this is a systole. Again, this is a non-shockable rhythm. Now, before I go into the management, there's something that's known as the crash cart that I talked about. Remember that this crash cart, when you call that for a code blue, you're going to push this crash cart or this emergency cart. It's going to contain medical supplies. It's going to contain equipment that are used in emergency setup. It will have a defibrillator. It could be an AED, an automated external defibrillator, or a manual defibrillator. It consists of an oxygen tank and a mask. It consists of IV fluids and administration sets. It has certain medications like epinephrine, atropine, lidocaine. It has an ECG monitor. It has airway management tools like an endotracheal tube, a laryngoscopy, pretty much an intubation kit. It has CPR supplies, your chest compression devices, your CPR masks, and other medical supplies. And you must make sure that every time you are switching shifts and every time you are receiving a shift from someone, this crash cart is available and everything that you need is available, especially if you're working in the emergency department. So the crash cart is actually designed to be easily accessible and quick to transport to the location where your emergency is. So it actually provides healthcare professionals with the necessary tools to actually promptly and effectively respond. How do we manage patients? So I divided this into two aspects: of outside hospital and in hospital. So the first person that's on the scene, you notice that someone has fallen to the ground, they appear unconscious. The first person that's on the scene is going to remain with the patient. The first thing that you must always do is ensure that this patient is not in any immediate danger. If they are in immediate danger, make sure you remove them from that immediate danger. For example, if someone has been involved in a car accident and you see that the car has a risk of catching fire, quickly remove that person out of that car and put them at a safe place where they're safe from any other harm. Of course, do not put yourself at risk. For example, if someone is being beaten by a mob and they become unresponsive, don't go there and stop the mob from beating that person. I know it sounds unethical to do, but you will be beaten as well because they'll think you are an accomplice to this patient. So make sure everything is clear and you are safe. Then once you have done this, you can commence the resuscitation. Take note of the time when you're starting this resuscitation. You want to confirm your diagnosis first. Check if this patient is unconscious. Check that they are not breathing. Check that they're not breathing. Check for the central pulses. This should not take more than 10 seconds each. Call the person, shake them a bit, try and arouse them. Check the pulses. Check if they're breathing. This should not take more than 10 seconds. If this person is alone, then there's no other person that you can call for help around. Start doing your CPR. Call for help. Call for an ambulance and start doing your CPR. If you suspect that there is some trauma and this person had a cardiac arrest because of non-medical reasons, and there is some trauma, make sure that there's protection to the cervical spine. There are maneuvers that you can actually perform, placing your straightened forearms on the sides of the patient's head to immobilize the head. Even when you're moving the patient, make sure that the cervical spine is immobilized, because you may actually dislodge a fracture and cause things to be worse. So you call for help and the second person actually arrives at the scene, or there's more than one person that has arrived. If there's more than one person at the scene, make sure that you, who is most knowledgeable about this first aid, you are assigning tasks to different people. This one will be checking for the pulse. This one will be checking if the patient is breathing. This one will be doing the chest compressions. This one will be taking note of the time. And as someone is calling the ambulance and is calling for help. So if there's an AED very nearby, in our setup here, we don't have AEDs in public, but in different countries, you do have AEDs readily available at certain parts. Like, for example, at a train station, for example, at a bus station, you should have these automated external defibrillator. If those ones are available, call someone to actually go and get that external defibrillator. Then once the person with the AED arrives, then they must follow the instructions on that same AED. It's very easy to actually follow. So you first prepare the casualty that is there, the patient that has been involved. Make sure that you remove all their clothing from their chest. Make sure that the chest is dry. If it's wet, it shouldn't be wet. Dry it up. If there's any blood, wipe it off with their shirt or something, but avoid touching the blood as well. Then attach the pads of the AED. Of course, there's a nice picture on the AED to actually where you should place the adhesive pads. One of the pad is actually placed on the right side below the collarbone. The second pad is actually placed on the left side in line with the armpit, so in the axilla. there's a picture that shows where you should actually place them. You should stop the CPR briefly, and the AEDs actually sometimes can have a sensor, which you're also going to connect to the patient. So you stop the CPR momentarily once you place the AED, and some AEDs are actually automated. They'll give you a voice and they'll tell you what is coming next. They'll give you a warning. So it may either tell you that there's a shock that is needed. If there's a shock that is needed, then everyone should clear away from the patient. They shouldn't touch the patient. Then they should press the shock button. Otherwise, some AEDs will automatically shock. So they'll give you a countdown where you actually let go of the patient, you stand away, and then they shock the patient. If no shock is needed, it will tell you that no shock is needed. So you continue your CPR for another 2 minutes. Then after 2 minutes, the AED will also check the rhythm again to see if a non-shockable rhythm has become now a shockable rhythm. Because remember that it's not always that you're just going to get non-shockable, non-shockable, non-shockable. Sometimes it may convert to a shockable rhythm. So it will advise you to whether you need to shock the patient or you don't need to shock the patient. Then of course you continue the CPR. After, if a shock was needed, the AED will deliver the shock. You continue the CPR for the next 2 minutes. So remember, 2 minutes of CPR is about 5 cycles of CPR. So there are those that, like I said, are fully automated. They're going to be shocking the patient without you actually pressing the button. They'll just be giving you this voice prompts to stay away from the patient, and there'll be a countdown. So if the patient is regaining consciousness or starts breathing normally, or they become responsive, they are opening their eyes, they are coughing, they are speaking, you stop the CPR and you place them in the recovery position. Remember, you should leave the AED connected to this patient, continue monitoring their breathing and responsiveness, then wait for the EMTs to get to that area, then hand over to the EMTs as they take the patient to the hospital. When you're in the hospital and you actually sustain or see someone who has sustained a cardiac arrest, the first person on the scene, of course, has to confirm that this is arrest. If the patient is unconscious, they're not breathing, there's no major pulses, then you call for help and you arrange the defibrillator, you bring the crash cart to that site. Remember that if the arrest is likely due to asphyxia, start the CPR before you even start shouting for help. Start CPR before you start shouting for help. So the aim is for you to keep the oxygenation to the brain, to keep the oxygenation to the myocardium until a stable cardiac output can actually be achieved. You place your patients on a flat, hard surface and you lay them facing upwards. So you look, listen, and feel. This should not take more than 10 seconds. You look for any signs of life. You listen to if there's any breathing or any sounds that the patient is making. You feel for any breathing. If the chest is rising, if it's symmetrical, you palpate the central pulses, the carotid pulse, and you shouldn't take more than 10 seconds. If there's no pulse, you start your chest compressions. So you're going to be doing 30 compressions with 2 ventilations. So that's roughly 30 compressions and 2 ventilations. That's 1 cycle of CPR. In children, you're going to be doing 15 chest compressions to 2 breaths. That's what we use in children. So an average of 5 cycles is going to be roughly around 2 minutes. Remember that if you're like a novice and you're doing this for the first time, your dominant hand is going to be placed on the patient's chest. Your non-dominant hand is going to be placed over your dominant hand. If you are used to doing CPR, it actually doesn't really matter which hand is on the patient's chest and which hand is over the other hand. So the heel of one hand is going to be placed on the lower half of the sternum, and the other one is going to be placed on top, and you're going to interlock them together. I think there's a picture that I've put in the next slide. The shoulders should be in line with the sternum of the patient. Your elbows should be straightened and you don't bend your elbows. You're going to be using your weight to push this person's chest inside. So you're going to be depressing the chest at least about 5 centimeters. That's about 2 inches. And you allow the chest to recoil in between the compressions. So in adults, it's 30 compressions, 2 ventilations. In children, 15 compressions, 2 ventilations. Then there is a song that I want you guys to look up, which is known as Staying Alive. I'll leave it pinned as the pinned comment on this particular video that you can actually go and listen to. So keep that song in mind, because as you're performing, you should be moving according to the rhythm of this song so that you're aiming for 100 beats per minute. So you push hard and you push fast. And your ventilation is done via your ambu bag. If the patient actually has an ET tube, there's no need for you to pause for the ventilation. So there should be minimal interruption with the CPR. Make sure that you have people that are ready to exchange whenever someone is tired. So this is how you're doing it. So as you can see, one arm is placed, the heel is placed on the lower sternum, the other one is placed on top, and they're interlocking. The elbows are straight, the shoulders are in line with the sternum, and you're leaning into this person, or putting your weight into this person without bending your shoulders. So remember, in the usual advanced life support, you have your ABC approach: airway, breathing, circulation. But in this case, this person's heart has stopped, so circulation supersedes the airway. So CAB. So you want to also assess the patency of the airway. Open the air with a head tilt or chin lift. That's, of course, you're assuming that you have ruled out any cervical trauma. And remember, if they have cervical trauma, then the jaw thrust alone should be done. Then administer 2 rescue breaths with your ambu bag, then perform early endotracheal intubation if need be, or use your supraglottic airway devices with end-tidal carbon dioxide monitoring. Do not delay CPR for you to put a basic airway device or even advanced airway maneuvers. Don't delay CPR whatsoever. The airway should be addressed early. If there's sudden cardiac arrest, that's due to hypoxia. And avoid excessive ventilation, because remember, as you are ventilating this person, you're increasing the pressures in the chest. This may actually affect the venous return. It may reduce the preload, and this can actually affect the patient's blood pressures and cardiovascular system. So if the tidal volume, or rather the tidal carbon dioxide, is less than 10 millimeters of mercury, then attempt to improve the CPR quality. Remember that the ECG should be applied whilst you're doing all these things. It's not like you're alone, you've called for help. A lot of people are each assigned roles. The ECG is actually connected, then you can connect your defibrillator or your cardiac monitors. Make sure that you have cardiac medications ready. Make sure that you have your lidocaine ready. Make sure that you have your amiodarone ready. Make sure you have your epinephrine ready. Make sure you have atropine ready. So you connect your defibrillator and you place your paddles and assess the patient's rhythm. So you place them in the conventional anterolateral position, or the sternoapical position. So the right sternal pad is going to be placed across the right of the sternum, just below the clavicle. Then the apical pad is going to be placed in the left mid-axillary line, approximately at the level where you put the 6th electrode, the V6 electrode. So this position actually should be clear of any breast tissue, and it is important that the pad is actually placed sufficiently lateral in practical terms, and the pad should be placed just below the armpit. So in this area, don't put it on breast tissue. So here's area and that area there. Of course, in the axilla, just below the armpit. Then if it's a pulseless ventricular tachycardia or ventricular fibrillation, you give them about 120 to 220 joules of biphasic, or you use 220 if you don't know what device you're using. For the older devices, which are monophasic devices, you use 360 joules. What do I mean? If it's a monophasic device, the rhythm is actually, or rather the electrical impulse is actually moving from one electrode to the other. So it doesn't oscillate, and can actually cause a lot of damage to the tissues, a lot of damage to the heart muscles. So it's usually better for you to use the newer devices, which are biphasic and can actually defibrillate the patient and send back the shock at varying, I could say, energy levels. So you then continue your 5 cycles of CPR, which is another 2 minutes. Then you reassess the rhythm. If the shock of a rhythm is still present, you repeat the first shock that you gave the patient and you charge it to a higher value. Remember, 120 to 220 for biphasic. If you have already started off with the 220 at the beginning, you repeat the 220. Then if it's a monophasic device, you give 360 joules of the shock. Then you give them 1 milligram of epinephrine, either IV or intraosseous, every 3 to 5 minutes. Then if you don't have epinephrine, you could use vasopressin, 1 dose of 40 international units. You continue your 5 cycles of CPR. This is another 2 minutes. So you then reassess the rhythm after 2 minutes. If it's a shock of a rhythm that is present, you repeat the dose of the shock, or you go to a higher value of the shock. At this moment, you should consider antiarrhythmic drugs. So it means you should have shocked. This is the 3rd shock that you're delivering to the patient. Consider antiarrhythmic drugs. Consider giving them amiodarone, 300 milligrams IV, once, then you can consider giving them 150 milligrams once, or lidocaine 1 to 1.5 milligrams as a first dose, then 0.5 to 0.75 milligrams per kg IV, and you can actually have a maximum of 3 doses or 3 milligrams per kg. You should consider magnesium sulfate in some cases, especially for those patients that have torsade de Pointes, which are these twisting points on the ECG. Give them 1 to 2 grams IV. If it's a non-shockable rhythm, you checked your rhythm, it's a non-shockable rhythm, you don't shock the patient, so you give them epinephrine. You give them 1 milligram of epinephrine IV every 3 to 5 minutes, so you can give them 1 dose of vasopressin 40 international units and continue your CPR. For those patients that have asystole, for those patients that have slow pulseless electrical activity rate, you can give them atropine 1 milligram IV every 3 to 5 minutes and give it up to 3 doses. So if the patient actually becomes responsive and you place them in the recovery position, you keep the ECG monitor, you proceed to post-resuscitative care. We are going to be searching for the possible causes. They are what we call the H's and the T's. Hypovolemia should be addressed, hypoxia, high region ions in terms of acidosis, hypo and hyperkalemia, hypoglycemia, hypothermia, toxins, tamponade, cardiac tamponade, tension pneumothorax, thrombosis, be it of the coronary or even the pulmonary artery, trauma. All these things should be addressed, because if they're not addressed, the patient will arrest again. So here is a schematic that is an algorithm that shows you how you're going to be managing the patient. So a patient comes in, they have arrested, you're called for help, you start the CPR, you give them oxygen if it's available, you have attached your monitor. Once you attach your monitor, you check the rhythm. Is the rhythm shockable? If it's shockable, if it's a ventricular fibrillation or a ventricular tachycardia, then you give them 1 shock. Either for the manual devices, if it's biphasic, which are the newer devices, 120 to 220 to 200 here, some of them are 220 joules. Then if it's an AED, it's actually device specific and it's automated. If there are older monophasic devices, 360. You resume the CPR, you do another 5 cycles, you check the rhythm again. If it's still shockable, you repeat the shock, you resume your CPR, give them a single dose of vasopressin, give them a single dose of epinephrine. You can repeat the epinephrine every 3 to 5 minutes. You check again that this is a shockable rhythm. After your 5 cycles, if it's still a shockable rhythm, you repeat the same thing. At this particular point, you're considering your antiarrhythmics, you're considering your amiodarone, you're considering your lidocaine, you're considering your magnesium sulfate. If you have checked your rhythm initially and it's not shockable and it's an asystole, of course, you're going to resume your CPR 5 cycles. You give them epinephrine or your vasopressin single dose. Epinephrine is given every 3 to 5 minutes. Then, of course, you may consider atropine in the cases of asystole and slow pulseless electrical activity. You check your rhythm again. If it's shockable, then you go and manage them as if they're having a shockable rhythm. If it's not shockable, and if it's systole, you repeat this cycle of the non-shockable arm. Then, like I said, push hard, push fast. Ensure that there's full recoil of the chest. Minimize any interruptions in the chest. 1 cycle of CPR is going to be 30 chest compressions, 2 breaths, and 5 cycles is going to be approximately about 2 minutes. Avoid any hyperventilation, secure the airway and confirm the placement of an endotracheal tube if you have intubated the patient. And after your advanced airway has been placed, then the rescuer actually no longer delivers cycles of CPR, so they just do continuous chest compressions and they give about 8 to 10 breaths per minute, and they should check the rhythm every 2 minutes. Then rotate the compressions every 2 minutes with rhythm checks, and of course search for those H's and the T's and address those H's and the T's if this person becomes responsive. If there is a serious dysrhythmia, for example, ventricular fibrillation, asystole, there is virtually no survival if the heart electrical activity is not restored within 10 minutes. So your chest compressions are only going to be perfusing organs, like I tell you, they don't stop the arrhythmia. The chest compressions may either push the blood out of the heart when you directly apply pressure to the heart, you call that as the cardiac pump theory, or they may create this negative pressure gradient between the intrathoracic arteries of the chest and the extrathoracic arteries of the body, what we call the thoracic pump. Remember, your goal is to maximize the coronary perfusion pressure, which is going to be the aortic diastolic pressure minus the left ventricular end diastolic pressure. And your coronary perfusion pressure should be at least about 15 millimeters of mercury to achieve ROSC, which is the return of spontaneous circulation. Remember that previously it was recommended that we do CPR for around 15 to 20 minutes, but newer studies have actually shown that longer CPR can even be done up to 38 minutes or even up to an hour, depending on certain factors. And these are the following things. Number one, the overall health of a patient. If this patient doesn't have any significant comorbidities, you want to save this patient. If this patient is quite young, you want to try and save this patient. How quickly the CPR is initiated. It's better if someone who's a medical trained personnel has witnessed a cardiac arrest and initiated the CPR very early. And the quality of the CPR, if you're doing good CPR, quality CPR, it can even go up to 1 hour. Whereas most of the studies show that there is a benefit for extending CPR, the best chance of survival actually remains within the first 16 to 24 minutes after you witness the cardiac arrest. I really hope you enjoyed this video on cardiac arrest. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. I will leave a link in the video for the flowchart for the cardiac arrest for those that were not able to zoom on the video and for those that were not able to see. Until next time, my name is Dr. Moses Kazevu. Bye-bye.